How do you reduce dark circles? This is one of the most common reasons that patients present, particularly in their 40s and 50s, and it's to do with that shadow underneath the eye. Unfortunately, this procedure is full of pitfalls and potential complications. So let's have a look at how to reduce dark circles. So last week I treated a patient and she presented with a sense of tiredness when she looked at herself in the mirror. I identified that the shadow underneath her eye was one of the key reasons why she may appear tired in certain circumstances. So the next challenge for me as a clinician is to decide whether the type of shadow that she's got is actually improvable with a dermal filler treatment or whether I need to recommend something else. Before we dive in, don't forget to like and subscribe so that you never miss an episode. It's important to note that there are actually two types of tear trough, I believe. There's a primary and a secondary type of shadowing. So primary tear troughs children have. You'll often see children with a shadow underneath their eye. In fact, my children have slight tear trough shadows. Now, these shadows can trigger some patients to present often in their early 20s and early 30s when they've actually always had the problem. The tricky bit for clinicians is that these are the hardest tear troughs to treat. So it's always important to think about how long the patient has had the shadow and whether this is to do with a really strongly attached tear trough ligament or whether it is to do with aging, which is the secondary tear trough problem. So secondary tear troughs occur as the face ages, you develop a shadow, and there are actually multiple different reasons why this can happen, but they are different to the primary tear trough. When treating secondary tear troughs, we usually have a bit more power to get a good result because we're correcting an imbalance in the fat pads that causes a shadow. And because this imbalance in the fat pads is to do with aging, we can often correct where the volume has decreased to hide or blend in some of that shadow. But we can't do this quite as easily in a young person with a primary tear trough shadow. The ideal patient to treat is someone who has a secondary onset tear trough. That means they never used to have it and now it's developed. And you may also be able to tell by examining the patients whether it feels quite tight in the area. So if it's quite mobile, you can also test with a cotton bud pushing underneath the ligament. If it elevates outwards, that gives you another clue that you may be able to project the skin outwards, which means it'll catch the light differently, which means you'll reduce the shadow. So you can do things on examination and on history that give you a bit more certainty about which type of tear trough it is. So why are so many clinicians and patients a little bit afraid of doing the tear trough area? Now, there is good reason for this. It's because it really is the area most likely to need to be reversed. So a lot of clinicians will say it's not worth the risk, and this might be true in some hands, but not true in others, and true in some patients, but not true in others. So we have to figure out what are the variables that are making it not worth the risk, and how can we mitigate some of those risks. The first thing is the most common side effect from tear trough is simply having visible filler. So you have a treatment, the filler may improve the shadow, but you get some other shadow or a bulge or a shape or maybe some translucency or Tyndall effect that essentially becomes another distraction, which means it's not worth having the product, and we end up having to reverse the whole procedure. This happens in a cohort of relatively new injectors of maybe less than 2 years experience, probably about 5% of the time. That's certainly what I found when I audited a group of clinicians. This is not too high, but it's probably the highest rate of reversals of any procedure that we do. And it's because there really is no room for mistakes. Very, very thin skin, right where your line of sight is, the most visible part of your face, with only 0.2 millimeters of dermis to hide any imperfections. So it does take a lot of practice and careful injecting to be able to consistently get good results. But most importantly, also takes the right product. You can't use just any product in this area, and it takes the ability to select the right patients. You should actually be saying no to a lot of patients who ask for treatment in this area or may have a shadow underneath the area because they need something else. Often it's surgery. Let's break down the potential risks and think about how to reduce the risk of each one. Now, a lot of people worry about blindness in this area. It's actually not a particularly high risk area for blindness because most of the vessels are not in this area. If you think about the vessels most likely to be associated with blindness, it's non-surgical rhinoplasty, glabellar treatments, it's the supratrochlear artery, and we are actually not going that close to the supratrochlear artery. I know to the untrained eye, we are getting quite close medially, but it's probably about 1 centimeter away in most patients, which in my mind is quite a big difference between high risk and low risk. Product matters a lot because if you use a standard product, what you get is an attraction of fluid afterwards. Now, when I first started in aesthetics, I didn't have access to any of the newer products. I did start doing tear troughs after being trained, and the rate of reversal was higher And I was very afraid of doing tear troughs. I used to do very tiny corrections. Basically, I'd almost try not to do tear trough, put tiny amounts in, and then still sometimes you get puffiness that happened later. But it did make me very good at doing tear troughs cautiously because I was so afraid of failure that I was in a different zone compared with many of the other parts of the face. But choose the right product and things get easier. After choosing the right product, assuming that you've also done the work necessary in other parts of the face. The tear trough is affected by volume in the cheek, both laterally and medially, and often you can improve the tear trough and make it much easier to get the final improvement by doing the surrounding areas first. This is probably the topic for another video, but please think holistically and don't just inject the medial third of the tear trough on its own. We've got to think about the cheek, the tear trough on both the lateral aspect, so the lateral orbital junction, and also the medial aspect, and not just fill that medial third like many trainers seem to do. For me, that creates a very unhealthy look where the lateral lid cheek junction is depleted and the medial aspect is more likely to look overtreated. So be holistic and you'll get better results. When it comes to actually treating the tear trough, we need to be thinking about how to reduce that risk of edema. So we've used some questions to rule out patients at risk. So the primary tear trough is one patient you wouldn't treat, but also ask about periorbital edema, particularly in the mornings. If the patient is very puffy in the mornings, this can be a clue that after the procedure, they're going to be even more puffy. And this is why we want to be using low doses, no matter what we're doing or which patient it is. We try and keep the dose as low as possible. And the second line of defense is to, I believe, to inject more deeply. So wherever possible, I'm trying to inject on the periosteum. I've always felt that with a cannula, you gravitate more towards the middle level because the cannula bounces off anything that is resistant, so connective tissue in the dermis or the periosteum. You end up injecting usually in an intermediate depth, which is much more superficial and much more likely to show up as lumpy or bumpiness or puffiness after the procedure. So I'm always trying to put low doses on the periosteum, and I do prefer using a needle, although I also use a cannula in certain people. So the first thing to do when you start injecting is make sure that you are where you think you are. Unfortunately, many clinicians do get a little bit confused in the beginning stages, and they think they're about to inject onto the bone in the shadow where the lateral lid cheek junction is, but actually it's the shadow where the lower lid meets the cheek, and that's actually just above the orbit, and you can go straight into the orbit through the orbital membrane if you haven't checked this. Now, it does sound, if you're well trained or very experienced, this won't make sense to you because you've been doing it correctly for so long, but I've seen many clinicians in those early stages of learning start to point their needle towards the wrong shadow, and it's a very risky thing. So we always start by checking this periosteum underneath your needle. You can do this with a cotton bud, or you can do it with your finger, and you can of course do it with a needle before you start injecting. So you want to make sure that you're on a flat surface that's the periosteum and not pointing towards the orbit. You can see in this clip that I'm using a BD needle. I think there's some benefit to using a BD needle for new injectors. I actually typically don't, but I found it useful when training and when people are starting out with tear trough is to use a quantified amount. So you've decided how much you're injecting before you inject, and it's impossible to inject more than that. And this is helpful because one of the most common reasons why tear troughs are disappointing in the early stages is when a clinician has used, for example, a cannula, been a little bit heavy-fingered, heavy-thumbed, and ended up injecting too much. And then you end up with way too much product in an area where you can see it. So the advantage of using a BD syringe is I can quantify the exact amount I need and only inject that much. So in this clip, I'm using Juvederm Volbella. This product I've been using for many years. Remember, if you're in the US, like it's only recently been licensed, but we have been using this product since about 2013, 2014. So I have many years of experience with it. I absolutely am sure that it causes less periorbital edema than the other similar products like Juvederm Ultra 2. And I am not a rep for Allergan. I don't represent them at all. This is just my experience. I've also had a very similar experience with Redensity 2 if you would prefer using that product. Now, what I like about these products is they seem to attract less moisture and they're very malleable, so you can make an adjustment after you've injected them, and they seem to stay as they are when you first put them in, unlike many of the products that absorb moisture. I'm using a 0.05 ml bolus with each injection, and aside from aspirating, knowing my depth, knowing that there aren't arteries in this area, the rising of the tissue in this area is actually also a very reassuring thing that you are safe because you can see exactly where that product is going. It's not going into a vessel, and it makes me feel safe in terms of doing little boluses in this area. Make sure you like and subscribe if you found that helpful so that you don't miss the next show.